Welcome to Digital Health Talks, where innovators and changemakers share how they're transforming healthcare through technology. Join Megan Antonelli, who will be shining a light on the good things happening in digital health.
Hi, everybody. Welcome to Digital Health Talks. This is Megan Antonelli, CEO of Health Impact Live, and this is where healthcare operators come to have conversations that actually matter. Today's guest is someone that's doing work every single day on the front lines of one of America's most underserved communities. Dr. Adam Aponte is a board-certified pediatrician trained right here in New York City with 25 years of experience in community health. He is now the CEO of East Harlem Council for Human Services and leads Broken Neighborhood Health Center, a federally qualified health center that has been the backbone of East Harlem since 1965. They deliver comprehensive care regardless of insurance status or the ability to pay. HR1 is threatening $300 million in FQHC funding for New York, in just New York alone. Dr. Aponte is here to make the case that this is not just a community health story. It is a health system leadership story, and the stakes could not be higher. Dr. Aponte, welcome to Digital Health Talks.
Hello, Megan. Thank you so much for inviting me on this podcast. Really excited, this recording, really excited to join you and share our perspective from here in East Harlem, from the front lines, as you say.
Yeah, no, it's amazing. Looking at your career and your experience as a pediatrician, I think you trained at Mount Sinai. You have, been, working in this community for so long. And I think, I noticed in your bio that you joined right at the pandemic in terms of, really what that was taking hold in New York City. And that kind of speaks volumes about, what this work means to you. But in your own words, tell our audience a little bit about, your journey and how you got to where you are now.
Great. And thanks for allowing me that opportunity, because I often tell people, I say, you know my glory, but do you know my story, right? And I wish I would have quoted that line. I didn't quote that. Somebody else quoted it, but it just resonates with me as far as, how'd you get here? And, born and raised in East Harlem, New York, this is my community. This is what really kind of the major reason why I feel compelled and feel a responsibility to this community, because I was born and raised here. I was joking earlier with you that, from the time I can talk, I knew I wanted to be a doctor. And my mother says I've always said that I was going to go to Mount Sinai School of Medicine, where I grew up right around the corner from. And so that's what really drives me, right? That's my passion for this work, because seeing firsthand what we now describe as health disparities, something I really witnessed, and you're a New Yorker, so you know this, right? You know that distinctions between the Upper East Side and East Harlem, a community divided by 96th Street, that double yellow line, and how that line represents so many disparities between that community in so many ways: economic disparities, health disparities, housing disparities, you name it. And so witnessing that firsthand is what really drives me to want to make a difference in my community. So I've had a very, blessed, journey to this point, including, public school systems of New York City, City College of New York. Shout out to City College. Went to Mount Sinai, as you said, to do my medical school education there. Stayed there for my pediatric education, and have really stayed connected to East Harlem in one way or another throughout my entire career. I did work in Brownsville, Brooklyn, but my work has always been focused on underserved communities, marginalized communities, which, by the way, because they're underserved and marginalized, doesn't mean that they don't have special characters, right? East Harlem is a very rich, vibrant, culturally rich community, food, arts, resiliency, but unfortunately, it has its significant share of health inequities and health disparities, and it's time to change that. And so I had the chance to rejoin this particular organization that I've known for many, many years, the East Harlem Council for Human Services, during the pandemic. I was actually working somewhere else. I was working for New York City Health and Hospitals at the time, and reached out to the then CEO and said, look, you guys must be facing challenges, because we're all facing challenges. And really, we just wanted to offer my assistance. And, that conversation led to me coming on as Chief Medical Officer. And then almost 3 years now, I've been the Chief Executive Officer for the council. And as you mentioned, one of our major programs is the Broken Neighborhood Health Center, a federally qualified health center located here in East Harlem. The very first one, actually, in East Harlem, that's been serving this community for over 52 years now. The council since 1965, so 61 years serving, but the health center was created in 1974. Yeah.
Yeah, what an amazing journey, and really, we were neighbors. We were just a few blocks apart, but as you said, that 96th Street sort of border there puts two neighborhoods that are so disparate next to each other, and Mount Sinai so kind of sits in the middle there, serving both communities, but I think it's very important to recognize kind of the importance of FQHCs. And we talk about them a lot. We've heard about them quite a bit recently with HR1. But tell us a little bit in terms of, what role does that FQHC play there in East Harlem?
Yeah, so for your listeners and those people listening on this show, so federally qualified health centers are also known as community health centers. They came about during the Johnson administration, during the war on poverty. And it was a real effort to make sure that all communities had access to primary preventive care services. Fast forward 60 years, today in this country, there are over 1,500 FQHCs, actually closer to 1,600, serving over 35 million U.S. residents. So 1 in 10 U.S. residents gets their care in an FQHC. In New York, we're about 80 FQHCs with 900 locations serving 2.5 million New Yorkers. So 1 in 8 New Yorkers get their care in FQHC. And our goal and our purpose is to provide access to primary and preventive care services. That's the core of what we do. Over the years and decades, we've adopted some other additional services that we think are equally important to that whole person care. And we'll talk about whole person care, what that means. But our major goal is to make sure that no one's falling through the cracks. Everyone who needs and deserves primary care get it. And so we are equipped to see anyone, regardless of their ability to pay, regardless of their immigration status. We are a safety net. That's what we represent in the healthcare system. And over the last 6 decades, we have really evolved to be a major contributor to the provision of primary care services for so many individuals, such that if we did not exist, the health outcomes in this country would be so much more worse off. And so that's really in a nutshell what we do. And those services include, prenatal care, pediatric care, adult medicine, dental care, behavioral health services. We often have a pharmacy on site, really make that one-stop shopping for individuals and help them navigate this very complicated healthcare system, right? And when I say complicated, it's complicated for all of us. I don't care what your educational attainment is. It's a very complicated and not easy healthcare system to navigate. So you imagine someone who's a recent immigrant, someone who doesn't speak the language, and now dealing with all these chronic conditions like diabetes or hypertension, and having to see all these specialists, all these ologists, as we often say, right? Endocrinologists, podiatrists, optometrists, right? And navigating all that stuff, or someone who just gets diagnosed with colon cancer, a very scary disease, breast cancer, and helping to make sure that they get the care that they need at the time that they need it, in the place that they need it, right? So that's what we represent in the healthcare ecosystem of this country. And, we have to make sure that we continue to get the support that we need to do this work.
Yeah, this importance of the safety net can't be understated. And the fact that, it is, it's part of the community, right? And it's perceived as part of the community. Let's talk a little bit about, kind of what's going on with HR1, what that means for a center like Broken, and what's at risk.
All right. So we're gonna get you to say Borinquen the right way, Megan, but I know you're making a good effort at it. We talked about it earlier. And for those of you who don't know, the way we actually spell Borinquen with a K, it derives from the original name of the island of Puerto Rico. So that the Taínos used to call the island of Puerto Rico Borinquen. And that's why you'll hear some Puerto Rican people call themselves Boricuas. It's a play off of that word. And then the Spaniards came in and changed the name to Puerto Rico, which means rich port. And then that history goes a different way. That's another session for us to do in terms of
yes.
But HR1 is very challenging in that it really is focusing on Medicaid, which is a lot of the work that we do is on Medicaid recipients. The next population is uninsured, but our biggest population of individuals that use health centers like ours across the country are individuals who are recipients of Medicaid. And so with HR1, there is going to be diminishing individuals on the Medicaid rosters. So with some of these changes in terms of how often someone has to recertify for Medicaid, you used to have to do that once a year. it's not a daunting process, but it is a challenging process. And if you miss that window, you can be uninsured for a period of time. So having to do it now twice a year is going to be more challenging for our patients. The lack of continuous enrollment for children from newborn to 6 years old. So in a state like New York State, when a child was born in the state on Medicaid, they had continuous enrollment until they were 6 years old. And the reason the state did that was to ensure, I'm a pediatrician, as you mentioned at the top of the hour, right, is that children get the early child care that they need to ensure that they start off life healthy, right? All those really, really important things, despite what you hear, immunizations are important, monitoring developmental issues, monitoring height, weight, all those issues that we want to address early on. We know that when we address them early, that child will have a much more healthier life. So New York State did that intentionally so that children would never face not having insurance to get the services they need. So that's going to go away with HR1. And we anticipate in New York State alone that the revenue loss because of people getting off of Medicaid, becoming uninsured, is estimated $300 million in revenue for FQHCs that already operate on such tight margins. And so how are we going to make up that gap? And by the way, those people who lose insurance, we are still going to see them. We're just not going to get paid to see them. Right. And in New York State, they have these charity care pool dollars that get distributed, but that's a zero-sum game. It's a tight pool. There's no talks about increasing that allocation, yet we're going to have an increased burden of uninsured individuals either coming to our health center, which preferably they come to, but if not, they're going to start going to the emergency room, urgent care. And those are not places where you get primary care.
Right. Mm-hmm. Of course. I mean, the patients they don't stop getting sick just because they don't have coverage. And I think, the point you're making around the requirement to, reinstate and reapply is so important because that's one of the barriers in the first place, right? I mean, so often patients come who need Medicaid, who qualify for Medicaid, but maybe aren't already on it. And they have to go through that, when they're sick, let alone having to redo it every year. And, talk a little bit more in terms of the pediatric piece of that, what those implications are, for the healthcare system as a whole, for kids to be losing that coverage, right. Between zero.
And so they'll have to just to clarify, they have to recertify twice a year versus once a year.
You're listening to Digital Health Talks. When we return, we'll continue our discussion on how technology is revolutionizing healthcare delivery. Stay with us to hear more insights on creating sustainable, patient-centered digital health solutions.
And by the way, what I didn't mention, I failed to mention, I'm sorry, is the new work requirement as well, right? So there's going to be a work requirement for able-bodied individuals who don't have children under 14 years old, between 14 and 64, that they have to either work, volunteer, go to school for 80 hours a month. That's a part-time job. And so how are people going to fulfill that requirement as well? Getting back to children, right? Again, this is the key place where we should be making the most investments in terms of our healthcare system versus the tail end of life. And when you look at the healthcare system and you look at expenditures, a lot of the expenditures are in the latter years of someone's life versus the formative years of their life. And so clearly, a parent who has a child who doesn't have access to health insurance may not be able to get to a doctor unless there's an FQHC in their neighborhood. And while we take care of 2.5 million New Yorkers, there's still a lot of places that we don't exist. When you look at, rural upstate New York in particular, the distance between FQHCs is tremendous. Here in the city, the 5 boroughs, you can probably find someone easier. But, a large part of our state is rural upstate New York. And so where are those individuals going to go to seek care? And so, you're going to see certain preventable illnesses manifest themselves in children due to this lack of coverage, this continuous coverage or loss of coverage. Most of these children will be eligible, but to make that barrier, and that's what I really think about, is an obstacle. You're making it more difficult for people who are already dealing with so many challenges. Why are we making it more difficult for them to get the healthcare that they deserve? And by the way, that's an investment.
Right.
the more we invest in that early sort of childhood healthcare, the less likely that they're going to be a large expenditure at the tail end of life, right? It's that sort of ounce of prevention, pound of cure analogy that we use. It sounds very cliche, but it is so true in medicine beyond, what you may apply that to in other places. It really is so true in medicine. And so that's why it's important for us to really focus on that. If we want to curb healthcare expenditures in this country, and I do agree that there is some elements of fraud, waste, and abuse, it's not in the FQHC world, though. It's not what we're doing, right? There are other areas that we need to focus in on, and that's okay. I think there's a prudence for that, but I think the impact that it's having on organizations like ours is extremely significant, and the consequences are going to be dire.
Right. And obviously the financial elements of that, and the paperwork requirements to have people to re-up their membership, their eligibility status, and in an environment where we already talked so much about kind of a lack of trust and lack of usage of services, right? I mean, part of pediatric medicine is about getting people in the habit to go to the physician, to go to, to trust their doctor, to build those relationships. And in these communities where that's even, that's more needed and more necessary, you're creating barriers to that. So, I think talk a little bit about, as you've seen, sort of working in that community for so long, that importance of the community, expecting those health systems to be there for them, and how that trust, kind of matters for care delivery and the continuity of care.
Yeah. And, you're so right. The key to pediatrics is helping children to adopt healthy lifestyle choices from early on, right? And one of the reasons I went to pediatrics was because I felt like it's going to be very difficult for me to take an adult who's been smoking 30 years to get them to quit. It's going to be a lot easier for me to take a child who's never smoked and get them to never smoke, adopting healthy lifestyle choices. And then you talk about trust, right? And so the way this manifests, these changes to Medicare, Medicaid in our populations, is that people feel like they're back, people are turning their back on them, right? And the communities already where they have this sense of distrust for sort of, establishment, right? Because rightly so, because, you look at East Harlem and there's just so many health inequities that people have had to deal with for decades. And so now we're further compounding that distrust by taking these kinds of measures. And so it makes people feel like, the hell with it. What am I going to do? They throw up their hands. They feel like the system is out to get them. And that kind of behavior leads them to start to do interact differently with the healthcare system, including neglecting their own health for fear of the cost of it, right? You go to the emergency room, you get a bill for $500, $600 the next day. And when you're living on, paycheck to paycheck, if you're living that well, that is a tremendous fear for individuals, right?
Yeah, no, I mean, there's no question. And just the impact of, thinking you have coverage, but coverage lapsing because you didn't, sort of jump through the hoops of that eligibility piece of it. And then, I mean, as you said, in terms of the work requirements, well, on one level, seemingly, a reasonable ask, but then on the other hand, you're talking about, a population of single parents and where that level of work might be difficult, to achieve, or disabilities or what have you. So, or, various age and various reasons. So in a time where, completely able-bodied, fully whatever people are having trouble getting jobs,
Well, not only getting jobs, but making livable wages, right? I think that's the other part of it, right? I think the misconception with people is that people want to live off the system. No one wants to live off the system. It's not that luxurious to live off the system. I grew up poor in East Harlem because we just didn't have the means, right? That wasn't a luxurious lifestyle for me as a kid, right? My father tried to work as much as he could, raising the family that he had, but it was very challenging to make that livable wage. Most people, if not the vast majority of the individuals that I work with, they want to work. They want to contribute to their own well-being, but they can't find work. They can't make livable wages. They're taking care of several generations of families that prevent them from being in the workforce. people have a misconception of these sorts of things. When I used to teach students a lot at Mount Sinai, and even when I was a student, many of my colleagues did not have the perspective that I had growing up in East Harlem, right? And so they see someone who has substance use disorder, and they feel that person made conscious choices in their life to use, illicit drugs. And I pushed back on them. I was like, no one I know ever grows up to say, I want to be a drug addict when I grow up. I want to be homeless when I grow up. There are circumstances that lead people to these situations that often are beyond their control. And then once you're there, how do we help them move out? More importantly, how do we prevent them from going down that route? That's where I want to focus my time and energy. But once they're there, right? But nobody chooses their circumstances. Nobody says, I want to grow up to be poor and homeless, right? That's not a conscious choice that we make. Those are circumstances that create that. And so we have to really think about what contributed to that person. And yes, you know what? If they can't work, no problem. But where are they going to work? What kinds of jobs can they find? Depending on the skills they have. So, is there vocational assistance to get them a skill so they can have meaningful work? And trust me, if you put that in place, so many people would be excited to have that because it gives them purpose in life.
Right. Which, of course, is the role of these safety net organizations, is to build that trust, be there for the community, and help them to understand that those resources are there and available to them. And when you take them away, it just breaks the trust and breaks the willingness and interest in using the services that are there. I mean, and I think that's been such a huge problem. Sort of the fundamental problem of Medicaid is exactly what you said, that people don't want to use it. They don't want to be on, that service. And so taking it away to those who do and who are benefiting from it and making it more difficult to use is counterintuitive to the whole program, let alone just, to capture some levels of fraud and abuse or whatever might be there. Right. But to talk a little bit, we're Digital Health Talks, we're technology, and there are components of this bill in terms of, kind of telehealth and technology to become available. And certainly where I sit and we try to talk about technology as a means for improving access to all communities, whether rural or less underserved communities, and how telehealth and all of that might improve access. It kind of comes back a little bit to that trust piece, right? Because if they don't trust what you have there, and if they're not giving you the right data, or you're not able to kind of engage them using those tools, then the tools aren't going to deliver on that promise, right? And I think there's this assumption that we can take this, the trusted away, we can put in some of these, sort of easier technology tools. But if we've broken the trust, it kind of falls apart. So tell me about, kind of where you sit and what you're seeing in terms of both, digital adoption, tech, literacy, what's available, and kind of frame that in, for the populations that you serve.
Yeah. So, so telehealth is not new, but I think obviously with COVID, we put fuel on that fire, right? We had to really escalate telehealth, and it did play a role. I will tell you though, my experience here in East Harlem in this community was that it was slow in the uptick, and still today, many people do not trust the technology. There's still a very old school mentality as well. Like, we like to come in and see the physician, be in person, and develop that relationship. You want to develop a relationship with this camera in front of me, right? I want to see the doctor and be in their presence, or the provider. And so, most of our patients did not adopt telehealth or embrace it to the degree that perhaps some other communities did. And of course, being in the city, it was a little easier. We never closed during COVID, so we always remained open. And so in that sense, we didn't have the adoption. It is a great tool. It is an absolutely wonderful tool that we can augment and utilize within the healthcare system, and it really will help us to deliver care. But we got to make sure that people know how to use it, want to use it, and understand the benefit, and make sure that they know that it's not being used against them. You talked about the data piece, right? It's amazing to me when patients walk into our health center and we ask them just fundamental questions about who they are, where they're from, income. They don't want to share that. They feel like, what are you going to do with that information? How are you going to use that against me? Right. And part of it has to just been like, decades of feeling like, people are taking advantage of you. Right. So we take a lot of time in education to say, it's important for us to know your income. It's important for us to know your race, ethnicity, because we use that to benefit and improve the services we offer, to understand you more. But most places don't take the time and effort to explain to people. And so what happens? They leave those questions blank. They don't answer those questions, right? And so we lack that data that we need that will help us to further improve the healthcare delivery in the community. So it's kind of a vicious cycle in a bad way, right? We can't get the data. The data will help us to say, okay, we need to do more for this community, but the community doesn't want to provide the data, right? And so, we get it in other ways, but it's one of a challenge. But it hasn't been the solution for our communities. I think we need to do better jobs of making people feel comfortable. But on that note, I will tell you, there are challenges today for telehealth for FQHCs. So in the world of telehealth reimbursement in New York State, if my patient and or my provider are not within my brick and mortar health center, I get paid a third of the rate for that visit. Yet right. I still hire that provider. I'm still paying that provider the same amount of salary. I'm still providing that patient with the care that they need when they need it. But New York State doesn't reimburse us fully for that. Mm-hmm. I don't understand that, right? And that creates further of a barrier for us to adopt telehealth technology because we're going to be challenged in terms of how do we afford that, right?
Right. And while we're seeing progress kind of on the national level, that if that still exists there, building that trust, which is fundamental, and then the sort of, resilience of using the systems, it's not there, it's certainly not going to be a safety net to the safety nets, if you will. So, I think it's really interesting. And I think the discussion around the data, so much as we talk about, the usage of social determinants of health and how to provide better care. But if we're not explaining why we need that data, and that takes time, and we know that our physicians and our nurses don't have a lot of time to make those explanations and to make people feel comfortable with that sharing, and if they did, we wouldn't have to have this conversation about the broken health system. There'd be those resources there. But it's been such a pleasure to kind of talk to you and to learn about the work that you do across East Harlem is really a model for community-centered care. And I think the connection between the data and the trust and the importance of that safety net can't be understated. So I really appreciate your time and the work that you do. And I think in terms of how folks can kind of follow up, we'll put that in the show notes. We'll be sure that they can find it online. And to our audience, if this conversation has moved you, please hit the like and subscribe button and share it with a colleague who needs to hear it. And you can visit us on healthimpactlive.com for the full library of Digital Health Talks episodes. This is Megan Antonelli, CEO of Health Impact Live, signing off for Digital Health Talks, where healthcare operators do the real work that makes healthcare better for everyone. Until next week, let's keep fixing healthcare one conversation at a time.
Thank you for joining us on Digital Health Talks with hosts Megan Antonelli, Janae Sharp, and Shahid Shah. For more insights on healthcare innovation and a deeper dive into today's discussion, visit healthimpactlive.com. Join us next week as we continue exploring the technologies and strategies transforming healthcare.